Okay, we'll go ahead and get started. Once again, for those that are just settling in, my name is Leanne Foster, and I am a Provider Outreach and Education Specialist here at WPS. I would like to welcome all of you to our session today, titled Summer E&M Road Trip, Fueling Your CCM Knowledge. This is the first in a two-part series. The second part will be tomorrow. Ashley will be facilitating a second part of this series focused on CCM. Today's session will focus on the base of chronic care management and complex chronic care management and give you that base knowledge and help you understand that. Tomorrow is going to be an opportunity for you to hear more information on common denials and rejections associated with CCM and complex CCM, but also an interactive activity that's going to allow you to apply your knowledge today. Registration is still open for that, and later on in the session, we will be providing you with that registration link. So if it's something you're interested in, you do still have time to attend that. It is at the same time. We are at 12 Central to 1 Central time, but it will be again tomorrow. So for today, our goal and our objective today is to help provide you with a better understanding of chronic care management and complex chronic care management, including what services are included and the billing requirements for those. So to accomplish that today, we are going to provide you with an overview of chronic care management and also that distinction of complex chronic care management. There's a lot of similarities, and we'll talk about what the one real difference is. We're also going to talk through what CCM eligibility looks like for both patients and the providers that are providing the CCM services. We will talk about those required elements to qualify as a CCM service. That goes into that overview of what it really is. And then we're also going to talk about CCM billing requirements. And this is going to include some of those codes. Now, we did receive some questions about documentation. It's a fantastic question, and we'll touch on that throughout the session today as we talk about the items that are required for CCM, and we'll talk about how that needs to be documented. So to start out, hey, 1 second, there we go. Screen didn't want to move for me. Thank you. So to start out, I want to just give a quick overview of what CCM and chronic CCM is. So Medicare offers chronic care management as a benefit, and it's a program that provides additional support to Medicare beneficiaries who have two or more chronic conditions. Now, we often get the question about what is Medicare's definition of chronic condition, and a chronic condition for Medicare is a condition that is expected to last 12 months or until the patient's death. We will also often get questions about, is it not chronic until it's lasted 12 months? And that's a distinction I want to make. It's expected to last for 12 months or until the patient's death. We're not wanting them to necessarily have had it for 12 months because the idea of chronic care management is to take a more proactive approach to the patient's care. So along with it having expected to last at least 12 months or until the patient's death, it's going to be a condition that is placing the patient at significant risk of death, acute exacerbation, decompensation, or functional decline. So it's going to have a real impact on their overall health status. There are a couple of categories of chronic care management. You've heard me mention it a couple of times. There's chronic care management and there's complex chronic care management. As we go through this today, both of them have the same requirements for eligibility, and they include really the same services and the same documentation requirements. Again, those two or more chronic conditions. But the main difference is going to be the level of complexity required in the medical decision making for that patient's condition. So they're very similar. It's just with complex chronic care management, we're looking at a higher level of MDM. The goal for both, as I said, is the same. It's to help the patients manage their health more effectively and hopefully reducing the need for any emergency department visits or hospitalizations. We want to help them live with their conditions, again, manage them versus be impacted negatively by them. It is a monthly service, and it does allow practitioners to bill for at least 20 minutes or more of care coordination per month. And we will talk about the time frames. We'll talk about the codes and that billing later on in the session, but I want to give you that baseline. I do want to be clear that this is per month. So this is a monthly service, a calendar month service, not a 30-day service. So it means you're billing for all of the time that you've provided CCM or complex CCM in June. And then in July, you'll bill for all of the time in July. So it's not going to span over months. It's not 30 days. It is calendar month. It's also a service that is going to be billed by one provider. So we'll talk about this, but the patient is going to designate the provider that is providing their CCM or their complex CCM, but they're only going to designate one practitioner for their care for that month. And again, we'll talk about that more later in the session, impacts in a couple of places. Your documentation is going to have to show the time that's spent with the patient. And oftentimes, once this is started, it is a non-face-to-face service. So it may not be direct patient contact. Um, we're going to need to know the time, who's provided that service, and what they're doing as part of that plan of care. Those are all things that need to be supported by the documentation. As I said, the goal here is early prevention of exacerbation of uh, chronic conditions, prevention of additional chronic conditions, and really to improve the overall health and patient outcomes. So CCM services are extensive, and the structure is intended to provide a more proactive approach to caring for that patient, a holistic approach. So as part of the monthly service, you're going to need to assess the patient's medical, functional, and psychosocial needs. So we're looking at the patient as a whole. You're going to be developing a care plan, which we will talk about, that's going to encompass all of this. So that assessment, it's part of what you're doing each month. It's typically, as I said, it's not a face-to-face service, and it could be a phone check-in, it could be text, it could be a video call. However, it does need to be a direct interaction with the patient to assess their needs. We're looking to see if something has changed and are there interventions that are needed there. Um, because each patient's health needs will be different, it has to begin with that assessment of that individual patient. And like I said, what's changed? Has any of their medical needs changed? Has their cognitive state changed? Are they have changes in their functional state, or do they have psychosocial needs that have changed for them? So this can include, just the medical needs. Functional needs would include just looking at their basic activities of daily living. So, do they need help dressing? Are they able to bathe themselves? Can they cook for themselves? Are they able to prepare meals and get the nutrition that they need or manage their condition through their nutrition? Good example, there's diabetes. Can they manage their finances on their own, or do they need them? Those are functional needs. Psychosocial needs, we're looking at what kind of support system do they have? Are they isolated, or do they have a support network that's helping them through this? Um, do they have a history of substance abuse? Is there something that needs to be addressed in that respect? It can also involve confirming that the patient is receiving any necessary preventive services. So did they go and get a mammogram? Are they getting their blood sugars checked? Are they getting their cholesterol levels checked? Um, Even preventive services, I mentioned mammogram, that may not be part of managing their clinical condition. It's part of improving that patient's outcome. So it's more than just those conditions. Could also be that you're coordinating care. Perhaps once a month you're reminding them that they have an appointment with their cardiologist. You're making sure that they're going to that care. You could also be reviewing their medications. Uh, you're ensuring that they're on the medications that's best for them. You're ensuring that they're still taking them. Are they taking them correctly? Are there duplications in their overall medication list? Is there something that needs to be adjusted? Are they having any side effects? Are they taking them as prescribed? That could lead to some of those side effects. So are they taking too much of it? Maybe they should be taking it with food and they're not. Those are things that you want to. You're also going to include coordination of care that's home or community based. So what needs do they have? Could they benefit from home-based Meals on Wheels? Are there senior programs that they can be connected to? Or are there other agencies that could be assisting them with their health care? You're going to document all of this. You've done the work, and as you'll find, you may already be providing many of these services. So you may have patients that chronic care management might make sense for. Again, you still need those two chronic conditions, so if you have someone with one, it's not going to fall into it. But perhaps you have somebody that would benefit from this type of service. Another part of CCM is going to be managing any care transitions. So this can include, as I mentioned with the cardiologist, this can include coordinating care with other health practitioners if there are others involved in the care, may or may not be. So it could be clinicians, could also be transitions between facilities. So maybe they had a recent ER visit and they were discharged and you're coordinating that care transition home. Maybe they had a hospitalization or inpatient observation. Are they, you're coordinating and helping with their follow-up activities and you're taking on that continuity of care documentation among all of those facilities and those clinicians. Part of that continuity of care is going to include sharing information with those other clinicians or facilities as needed. Maybe you're receiving information from them and you're incorporating that information into your care plan as needed because, again, you're managing that patient's chronic conditions. I've talked a lot about chronic conditions. I do want to provide you with some examples. So, like I said, CCM and complex CCM are services for those patients with two or more chronic conditions that is expected to last 12 months or until the patient's death, and it's putting them at significant risk. So CMS does have a resource, and we'll go out to that here in a second, but does have a resource that does outline some of these conditions, and here is that list. So things like Alzheimer's, dementia. It could be some type of cancer. It could be cardiovascular disease, COPD, depression, diabetes, hypertension, um, all of the things that we'll commonly think of as a chronic condition. And this is where I do want to go to CMS's website. I'm going to show you a resource here in a second, but one thing I do want to point out, if you search chronic care, on the CMS website, you will come up with a lot of resources and a lot of FAQs. There's even some videos on chronic care and how CMS looks at it in the regulations. We're going through that today, but there are resources available to you here. Uh, One I'm going to go into is this Medicare Learning Network article. This is a great resource as a base for chronic care management. And one of those is going to be second, I want to get list and search. One moment. I tend to search. There we go. But they will list different diagnoses in here, what's considered that chronic condition. It's not an all-encompassing list, and that was the reason I wanted to bring you out here. It's not an all-encompassing list. It could be any condition that is considered chronic for that patient. We often get questions about, is there a list of conditions? And there isn't. Every patient's going to be different. Uh, Something that would be kind of have a defined course and transient in nature for one patient or is temporary for one patient isn't for another. So those are things to consider when you're looking at that. There's not an absolute list, but your documentation has to support that the condition is chronic. It doesn't have to say the word chronic, though that may be a best practice. It could document the onset of the condition. They don't have to have had it for 12 months, but maybe they weren't receiving treatment and they've had this condition for more than 12 months. So maybe documenting that onset would establish that chronic condition, or just the prognosis. This is anticipated to last for 12 months or expected to be a chronic condition. Just making it clear if a reviewer were to review these claims that this is a chronic condition, and remember, they have to have two for CCM. As I mentioned, we do have non-complex and complex CCM, and the really big difference is going to be that level of medical decision making. Going back to that resource, there is going to be under the CCM codes heading in that resource. This is where you're going to see the chart that you see in your presentation. And this is where it will tell you. Now, the codes are slightly different again because there's that higher level of decision making, and we will talk about that later on. But that is the difference between the two, if you've heard that and often wondered. So why would a patient want to? We've given a lot of examples of that now. One, better outcomes. As I said, the idea is to take a more proactive, holistic approach to the patient's care. Now, there will be some out-of-pocket costs, and we'll talk about that in a minute, to the patient, because CCM services and complex CCM services are subject to copays and deductibles, but we'll talk about that here in just a second. In general, it's going to provide a much more whole patient approach to their health care, and as the practitioner and the staff are providing the services, you're looking at what's going on with that patient as a whole, not just an individual issue. We're trying to prevent things from happening or prevent things from getting worse and making things easier for that patient to live with. Because they are talking to the same people each month, you're building a relationship, you're building trust between the patient and the staff involved in their care. This trust will lead to them being more likely to share information if something is changed. They might be less likely to just deal with it or think it's normal. They may actually mention it, and they may be more open to listening to the advice on the care that they're being, the advice that they're getting on their healthcare, and maybe following through. Again, in, increasing the likelihood of better outcomes for them. You're not necessarily going to be treating everything that's going on with the patient, but you are aware of what other providers are doing. Like we said, there's that care coordination piece. It should lead to fewer emergency room visits. It should lead to fewer inpatient hospital stays. And again, that leads to that lower out-of-pocket cost. And it's kind of drastic. Right now, the inpatient deductible is above $1,700. And the copay for a hospital stay is an additional cost on top of that based on the length of stay, and it can vary. A copay and deductible for an outpatient service such as CCM, while there is a cost associated with it, when you look at the numbers, it is significantly lower and leads to just a better experience for that patient. So for providers, there's also a benefit here as well. So CCM services are, as I said before, more than likely services that you are already providing to some extent for your patient. You're already doing this, so you should be reimbursed for that work. So being aware of the structure of these services is going to help you go back and see, are you already providing these services? Are there patients that you could enroll in CCM? It's also going to lead to less fragmented care because you're going to be working with other providers. You're going to know what's going on with that patient. You're going to be more aware of everything. That's going to make it easier for you to coordinate care for the patient, less likely that they're maybe going to get a duplicate medication, for example. And that care plan you develop will include information from those other practitioners. Again, you're not going to be operating in the dark. You'll know what's going on. Some of your CCM patients will not require as many inpatient visits, which is going to leave more time for additional or more urgent patients. and an overall better experience for you. A lot of CCM services are provided by clinical staff, and we'll talk about that here in the next few slides. So let's look at eligibility. Talked about this a little bit already, but I did want to make sure that we called this out. For a patient to be eligible for CCM or complex CCM services, they have to have 2 or more chronic conditions. And again, they have to either lasted or be expected to last 12 months or until the patient's death. And they're putting the patient at significant risk of decomposition, could be putting them at risk of death or that functional decline piece. We want to make sure that they're meeting those and that that is documented or supported in that documentation. We talked about that. It doesn't have to say chronic, but we do need to see that the 2 or more are supported in the um, documentation. That's the first and foremost thing that they'll look for. For provider eligibility, your billing providers are going to be your MDs and your DOs. Your non-physician practitioners can also submit the service, so we're thinking physician assistants, nurse practitioners, those types of providers. They are going to be billing. And most often it's going to be the patient's primary care provider that's billing for these services, but not necessarily. We have seen these services, CCM services being completed by some specialty practitioners. Just remember, only one provider will be billing for these services. Only one provider will have that consent. It's not going to be something that's billed by their primary care and their cardiologist and their nephrologist. It's going to be one. So that's one thing that you want to make sure that you're looking at. I also want to call out that CCM and complex CCM is priced out for both facility and non-facility settings, meaning our RHCs, FQHCs, and our hospital outpatient departments, they can bill for this. Now, previously there was a code. It was G0511 procedure code that was used for these types of providers. That has been deleted. That is no longer a code. So you would be billing under the appropriate CPT codes, but there is pricing for both facility and non-facility. The other thing I want to call out here is I mentioned clinical staff can also provide these services. Now they're providing so under the direction of the billing provider, falling under the Incident to guidelines. They will have codes that they bill, but the concept is the same. The billing provider is going to be overseeing that care. The clinical staff are going to be following that plan of care, and that clinical staff is allowed when the services provided are meeting state law and licensure requirements, and it is going to be a service that's inside the scope that's allowed for those clinical staff. So those are things that you're going to want to make sure you're looking at. Like I said, they have different codes. It's not going to be a simple Incident to. If you need some more information on those Incident to guidelines, we do have some education out on our YouTube channel specific to Incident to. So next I want to talk about the required elements for CCM services. So when patients are coming into your office, you are going to need to have them sign a consent for CCM. Typically, patients are signing consents anyway when they come in. And what we're looking for with CCM is that it's permission to receive the services, it's permission to release information about their care to Medicare, and then permission for the provider to receive patient. This is another consent. CCM consent is a little different than that. It is separate because it's typically going to be for services that are not face-to-face, and there are going to be some specific requirements, but it could be part of those, uh, but a few more conversations have to happen. So we want to make sure in this patient consent for CCM that the patient is aware that the CCM or complex CCM services are available. We want to make sure that it informs them of what CCM is all about and how they're going to access and take advantage of those services. Also needs to include information about any possible cost sharing. They need to know that deductible and copay apply, but as I said before, it is going to be significantly less than the cost of inpatient care. It's also got to include the fact that only one practitioner can furnish and bill for CCM services during a calendar month. So they need to be aware of it's not going to be billed by their primary care, their cardiologist, and their rheumatologist. I'll throw another one in there. But they needs to make them aware of that. It also needs to make them aware of their right to stop CCM services at any time. You want them to understand the service that they're requiring. It's going to be part of a conversation. We're going to talk about the initiating visit here in a few minutes, and it'll be part of that initiating visit. You're not going to set someone up for CCM services without the consent or that conversation. Now, this consent does need to go into the medical record, not just administrative records. It does need to be part of that patient's medical record. We also often get questions about how often this consent is needed. So I want to be clear, this is not something that CMS has a specific timeline, meaning it does not need to be given on a monthly or an annual basis. It does need to be obtained once prior to the start of CCM services. There is a caveat. If the patient is changing billing practitioners. So for example, patient was seeing a practitioner and maybe that practitioner uh, retired, left the practice for another reason. They're staying with the practice and now they're going to be having a new billing practitioner for those CCM services. At that point, because that practitioner has changed, that consent does not transfer. It's a new billing provider. It's a new provider responsible for their CCM services. We need a new consent at that time. That does need to be part of the patient's medical records. So that's the only time that we're going to need a new consent. So you want to make sure you manage that. Patients with CCM, they're going to be working with various staff, but there's going to be one billing provider. So keep that in mind. Now, that consent, as I said, probably going to be part of an initiating visit because before a patient can receive CCM services, they must have an initiating visit. This initiating visit is really for new patients that have not been seen in the past year, so the previous 12 months. This is going to allow you to do that assessment that we talked about earlier and determine their eligibility for beginning entering into CCM services and developing that plan of a care. Now, you may have established patients that CCM may make sense. So for established patients, if they haven't been seen in 12 months, they will need an initiating visit. If they have been seen in the last 12 months, acceptable visits that can be part or counted as the initiating visit are going to be any medically necessary E&M visit or office visit, any annual wellness visit, or that initial preventive physical exam, so that welcome to Medicare, or if they've had a transitional care management visit. Those would qualify. It doesn't have to be its own visit, but in order to consider it as the initiating visit, especially if it happened in the past, that visit had to discuss CCM with them. If it did not, then it's not going to be part of that. And you still have to get that consent. Um, so keep that in mind as well. So for a patient that is entering into CCM and complex CCM services, there does need to be a comprehensive care plan for how those chronic conditions, remember 2 or more, are going to be managed. It does need to be centered. So as an example, different patients are going to have different needs. So let's say we have Bill and Susie, and they maybe have the same chronic conditions. Let's say we're looking at diabetes and hypertension. While their protocols and their general treatment plan for that condition may be similar, they are not the same patient. So your care plan is going to have to include things that may be specific to each patient. Maybe one has less controlled diabetes than the other. Maybe one is more stubborn and getting them to take their medications is a challenge. Maybe the other doesn't have someone to assist them and they need that assistance to manage their care. It's going to be super important that your documentation is going to show the patient specific details of that plan of care. You're going to be focusing on managing their chronic condition, but there are going to be things that are going to be different. It's not going to be standard for every patient with a certain condition. Again, similarities for sure, but likely going to have some idiosyncrasies. It does have to be an electronic care plan. And the reason for this is we'll get to it a little bit, but it is going to be care that's available 24 hours a day, 7 days a week. So that continuity of care. And if it's only in a paper copy, how are other staff members that are assisting in this care going to access that? This electronic copy is going to allow your clinical staff to access it in off hours should that patient or caregiver contact for assistance. Again, that plan does need to be the whole health and not just the two conditions, because again, um, we want to make sure that we're managing the patient's care in its entirety. You also want to provide a copy of that care plan to the patient and their caregiver. You have to have the permission to give it to their caregiver. Situations could be different, but that care plan should also include actions that and activities that the patient is responsible for. Maybe they're having to manage their diet. It's how they're taking their medication. Maybe it's follow-up visits, any other interventions that are going to happen. Maybe it's a change in their exercise plan, but what are they going to do to help maintain their health? And you want to provide that copy to them so they fully understand that. So here is a list of the information that is included in the care plan, and this is also available out in that resource that we went to. But first is going to be that patient assessment. We talked about it before, but these are the problems that are being managed and not necessarily just those two chronic care conditions. Those two conditions are what qualifies them for CCM, but now we're looking at that holistic approach. So you're going to want to do a cognitive and a functional assessment. You want to determine what kind of assessment is appropriate for your patient. They are not one size fits all. You're also going to want to ensure that they're getting their preventive visits timely. Do they have a need for a caregiver? Do they have one? Can that caregiver do what's needed for this patient? So that's all needs to be in there. You do want to look at their environmental situation. Is the patient homeless? Does the patient's home have heat and air conditioning? Depending on where you live, one or the other or both are necessary. Does that patient live with others and do they feel safe in that home? Those are things that you want to consider. It also needs to have clear goals. So what do you expect to happen? What do you not want to have happen? Certainly, we're trying to avoid the emergency department and the inpatient hospital visits, but you want to include those. Okay, what do you want to have happen? Examples. Maybe it's a certain amount of weight loss within a certain amount of time. Maybe they're needing to lower their A1C. Maybe they have to take steps to lower their blood pressure. How are how are you going to know that their care plan is on track? How are you going to know that they have achieved the goals? And it may involve adjusting the goals. This is a living, breathing document. So this is something that is the billing provider is going to have a hand in changing and making adjustments to. As we mentioned, care coordination, that's with those other providers, facilities, community resources. That's that collaborative approach. What are those planned interventions? I mentioned those. As I said, appointments. Is it blood tests every month? Do they have some type of monitoring they're supposed to do at home? But it's that regular tracking of their health status and making adjustments to that plan as needed. It's not set the plan and forget it or set the plan and hand off the patient's care. That billing provider still needs to be involved in that patient care. Could also include any patient education that's needed. We want to empower those patients with knowledge to manage their chronic conditions effectively and It may include education on lifestyle changes, self-care. For instance, with diabetes, it could be on nutrition, those types of things, but that should be in there. It should also include any supportive services that are needed or that are happening. Um, there's a lot to it. What I have included here is a chronic care management checklist, and I'm just going to go into that. So this is a resource that's kind of just a nice summarized resource for how chronic care should work all the way through. So this is something that if you're not utilizing or weren't aware of, or just new to CCM and chronic CCM, this is a resource that'll be very helpful for you. I mentioned access and care continuity. That's that 24/7 access. So as part of CCM, you must offer 24-hour a day, 7-day a week access to the clinical staff. Um, This is something that each office has to determine how they can carry out, and it is a business decision. CMS doesn't lay out expectations. So what does this look like? How are they going to access the care? Are they going to have a phone number? Are they going to have some type of portal access? That's something that's very common these days. How is it going to be communicated to clinical staff? We will get a question, particularly with a phone number about an answering service. That's not necessarily wrong, but they can't take a message for someone to call them the next day. They're going to need a protocol in place for there's an answering service. How do I connect this patient to care immediately? The idea is we're preventing those emergency department visits. So they'll need to identify how they should contact the person if they need something, meaning the patient or the caregiver. How are they going to contact the provider or the clinical staff if something happens at any time? It does need to be clear to them. It's going to be part of that care team. You're also going to need to designate that care team. Who's going to be involved in that? Which clinical staff? Is it another practitioner? But remember, you're only going to have the one billing practitioner, but the time is going to accumulate for the month. So we need to have that determined and shared with the patient and their caregivers when they're participating in that. But it is 24/7 access to care. So now we are going to talk about the billing requirements. First, I do want to talk about, we're going to be going through a lot of codes here. And the first one I want to talk about is that comprehensive assessment and care plan. We talked about that, what needs to be included in that earlier, but I didn't talk about the code. Now, typically that comprehensive assessment and care plan is part of that initiating visit, and it's not billed separately. However, there are going to be situations where that comprehensive assessment is not only going to be provided personally, but it is also going to be involve a level of effort that is outside of the usual scope for that initiating visit. If that is the case, there is an add-on code to that initiating visit. So is it what it will need to be documented why it is above and beyond and outside that usual scope. But if it is, and that documentation supports it, you can bill G0506, and it is an add-on code, as I said, to that initiating visit. This is something, though, that's not going to be billed more than once. It is billed at the start of CCM. So this isn't something that's an add-on code every time CCM is offered. This is going to be billed once. If it's billed after that, it's going to deny out. It is a code that is set up that way. But again, it is for something that represents an extensive assessment and care planning that is above and beyond. Here we have the codes that are billed for CCM. So this is non-complex chronic care management when it's billed by the practitioner. And what you will see out in that resource There is a section, I apologize for all the screen flutters. There is a section for CCM codes. We've been here before. If you scroll down, there is a chart that does outline all of these codes. This is going to be a really good resource, but we're going to walk through those. So it is going to be 99491 for the first 30 minutes. Again, remember you're billing this. It's a calendar month code. So for all of June, you want to add up all of your minutes. For the first 30 minutes, 99491, and then 99437 for each additional minutes that are provided by that practitioner. These are the same codes that are going to be used for complex chronic care management. Remember, this is billed by the practitioner. That's that physician, that's that non-physician practitioner, so PAs, physician assistants, nurse practitioners, nurse specialists, that type of thing, not the clinical staff. There are different codes for those, and we'll talk about that. But as I go into this, I do want to call out that you want to remember they're about the time spent on CCM. So you do not want to necessarily bill as soon as you provide a CCM service. Wait till the end of the month. Perhaps you provided 20 minutes at the beginning, or excuse me, 30 minutes at the beginning of the month, and then you include additional 30 minutes that you weren't anticipating. You could potentially bill both codes, but you can't bill them multiple times in a month. So that 99491, if you've already billed it, you bill it a second time, it's going to deny, and you'd end up leaving money on the table. So make sure that you're including all of the minutes. And again, a best practice would be wait till the end of the month, know what the time is, and then code appropriately for that service. Next, we are talking about services for clinical staff. Uh, these are going to be those clinical staff that are providing that service kind of under that incident to guideline, but they do have these codes. They have 99490 for the first 20 minutes and then 99439 for each additional 20 minutes. And as I'm talking about these additional minutes, you do need to meet the full um, time allotment in order to bill those codes. So for instance, if you bill for 25 minutes, you're only billing or had 25 minutes of CCM, you're only billing the 99490. You're not also billing the 99439 at the point that you're hitting the full minutes. So let's say you did 50 minutes, you'd be able to bill both codes. This is going to be for clinical staff that are completing complex CCM. Remember, I said the practitioners use the same CCM codes. Those are for that higher level of medical decision making. But if you have clinical staff that are following that care plan set by that billing practitioner, these are the codes that they'll use, and then the time frames are adjusted. So 99487 for the first 60 minutes, and then 489 for each additional 30 minutes that they're providing that service. Also, as part of CCM, Medicare does allow for billing of chronic pain management. This is part of CCM, but it does have its own coding, and it is a monthly bundle that is going to include things such as the diagnosis, the assessment and monitoring. So we're diagnosing why they're having the pain, we're assessing it, we're monitoring that. We're looking at their overall treatment management for that pain, medication management for that pain. Again, we're looking at that chronic care management. This is not an all-inclusive list. I do want to call that out. There's quite a bit there, and it'll be on page 9 of this resource, this MLN article that lists all of the things that are included in the chronic pain management. So this is going to be useful to you. Now, a couple of things to keep in mind though. This is the initial face-to-face, and there does need to be that initial face-to-face visit for chronic pain management. It does need to be at least 30 minutes in order to bill, and that's going to be that G3002, and then each additional 15 minutes is going to be that G3003. But it is Also, something that there isn't a code for the clinical staff, it is for that qualified healthcare professional. So we're looking at that physician or there's not those non-physician practitioners. I mentioned this, but I do want to call out, and I have included a slide that is just a reminder. Again, these are codes that are based on time spent with the patient, uh, depending on face-to-face or non-face-to-face. Again, most of CCM is going to be non-face-to-face. You do need to meet or exceed those times listed. You're not going to you can count practitioner time towards the clinical staff time. So as you're looking at the codes, maybe you have a practitioner who does not have enough time to count towards the CCM, but your clinical staff does. Add the practitioner time onto that, so you may be able to bill for additional services. Clinical staff time, though, is not going to count towards the practitioner time. Remember, you're counting all of the time, but the clinical staff have different codes and they're paid at a different rate. This isn't incident to, it is different. So just make sure you're taking that into consideration. We do also get questions about concurrent billing. So there are some services that can be billed in the same month that CCM services are being billed. First one listed here is going to be TCM, which is that transitional care management from a facility setting to a home setting. You could bill for both. However, the documentation has to be very clear about what time and services are TCM versus what time and services are CCM. You cannot count the time spent on TCM towards CCM. You can't double count that time. But if you have separate services, it is possible. So just make sure you're not double counting that time. You can also count or excuse me, bill CCM when there's another medically necessary E&M visit in the same month. Let's say you've provided your CCM visits, but the patient fell and broke their arm. That is a separate medically necessary visit that is outside of the scope of that CCM. It's a condition that wasn't part of that. That could be billed in that same month. Also, you can bill for add-on complexity. So that's going to be uh, that G2211 for that longitudinal relationship. But again, the documentation requirements for each need to be met, and you're not double counting things. RPM, which is that remote monitoring, and RTM can be billed in the same month as CCM, but it's one or the other. It is not both. And again, that documentation still needs to support both services. We're not double counting here. Things that are not allowed. So this is a list of services that you can't. Prolonged care, for instance. When you're submitting complex CCM, with CCM in general, you already have the code that is for each additional amount of minutes. So that prolonged care is really already accounted for in the CCM codes. So prolonged care is one that cannot be concurrently billed. You cannot bill for CCM or complex CCM in the same month. It's going to be one or the other, and it's going to depend on what's happening that month. They're enrolled in CCM, so you'll want to make sure that you're accounting for the appropriate codes when you're billing. Your both the practitioner and clinical services. So we talked about where the practitioner services can count towards clinical time, but clinical cannot count towards practitioner. You're billing one or the other, either the provider's doing the CCM that month or the clinical staff, and you want to account for the time there. You're not billing for care plan oversight. That is something that is part of CCM because, again, there's that comprehensive care plan. Also, end-stage renal disease and social determinants of health assessments, those have separate codes and they need to be billed with those appropriate codes. And as you've heard me say several times already, you're not double counting your time. You have to ensure that that is the case. So here we do have resources today. I have asked Ashley to add in one additional resource, which is another site that includes a lot of base information on chronic care management for a complex condition. She's placed that in the chat. I'm going to go ahead and open that up. So this is essentially a homepage for chronic care management, and there's a lot of good information. It does provide a more inclusive list of conditions that are considered chronic, along with what's in that article. And I'm going to scroll down. Talks about billing, and there are some resources as far as how to get started, how to set up your program. So I wanted to make sure that you had that as well. So we've only got a few minutes left, but I do want to check in with Ashley to see if we have any questions that haven't been answered in the chat.
Hi, Lan. We do not have any unanswered questions in the chat.
All right, thank you, Ashley. I do want to call out that if you think of any questions on CCM or Complex CCM, you do have 7 days from today to submit them. So you're going to send those to our education mailbox, and I've asked Ashley to place that information in the chat. When you send that, just in the subject line, put the title of today's session or CCM or the date of the session. That just lets those that are monitoring that mailbox know that they need to get that to myself and Ashley so that we can get those answers to you. So certainly drop off, think of a question, don't think that you can't reach out. That is certainly something you can do. So in the next few minutes, you are going to receive an email thanking you for attending today. Don't delete this without taking a look at it. It's a couple of things. First, that survey that I mentioned, there's going to be a link to that survey in there. Again, this is going to allow you to provide us with some feedback on today's session, what we did well, what we can do better, and again, those topics that you'd like to see us include in our education in the future. I want to thank you in advance for taking a few minutes to provide that to us. And along with the link in the email, I've asked Ashley to place a link in the chat, and you're also going to get a redirect when you leave the session. It's not malicious or spam. It's not taking you anywhere you want to go. It's just a redirect from our webinar software to the CMS Qualtrics software. The other piece of this email is if you're attending today's session for continuing education credits, while MACs don't offer those continuing education credits, our sessions are recognized by the accreditation certification bodies as contact hours towards those. So that email will serve as that certificate of achievement. If you didn't get it, one of two things happened. You attended by phone, and I simply do not have a systematic way to confirm your attendance, or it went to your junk or spam folder because our WebEx Messenger email address is not in your safe senders list. Check your junk and spam just to make sure it's there, but in either event, send us an email to that same education mailbox for questions. Let us know that you attended and the phone number that you attended from today. Once I confirm your attendance, I can get that certificate out to you. With that, that does conclude our session for today. I want to thank all of you for taking the time to attend today. We are all super busy, and I know it can be very hard to carve this hour out. So I hope you found this beneficial. We look forward to any feedback that you have for us. And I hope to see you in our session tomorrow. I did ask Ashley to put a chat for the registration for that. That session is the interactive session that's going to allow you to apply your knowledge and also talk about denials and rejections for CCM. So we hope to see you there and in future sessions. Again, thank you all for attending today. I hope you have a great day and continue to do well. You may now disconnect.